Okay, so this is lecture 6, and we're going to talk about inheritance with respect to multifactorial diseases. And so there is an increased importance of these diseases because we are living longer, and most of these diseases present at an older age. So there are genetic diseases which have incidence at birth, prevalence at about 25 years, and then population prevalence overall. And so if you have disorders due to only genes, so those are the genes that the disorders we've been talking about mostly, in which you have single gene disorders or you have chromosome abnormalities, the incidence is highest at birth. And then, of course, it's much lower at the age of 25, and the population prevalence is roughly about 4 out of every 1,000. Disorders due to a single gene mutation, and so this has an incidence, again, highest at birth. And multifactorial inheritance, of course, has an equal distribution of incidence at birth and prevalence, but the population prevalence is very high in these multifactorial inherited diseases. So we'll just talk a little bit about these diseases. So we have talked in the past about diseases that are influenced by many genes, and those are polygenic diseases. Oops, let me not erase that. And then we have what we're talking about now, which is multifactorial. And that basically means that it has both a genetic influence as well as something else, some sort of environmental influence. You can have quantitative traits that are going to have multifactorial inheritance patterns, such as blood pressure. So blood pressure, you can have some genes that are predispose you for having high blood pressure, but if you don't combine that with the external influences, such as stress and other potential influences on blood pressure, then you don't have high blood pressure. So just having the risk for high blood pressure does not mean you're going to present with high blood pressure. Now, quantitative trait loci are going to be those genes that are going to cause variations in these quantitative traits. So in this case, we have short versus tall, and then we have an equal distribution in the population, meaning that you have some people on the extremes of both ends. Some are very short, some are very tall, but most people fall within the middle. And so that's common among traits that have multiple influences of multiple genes. So an important concept is what's called a threshold model. And this is important for these multifactorial diseases because it's believed that once you reach that threshold, then you present with the actual phenotype. So in this case, we have genetic males and genetic females, and it's shown that their threshold. So you can see that this area over here, this high area, is where you present with disease. And you can also see that the threshold level for reaching that high area is much lower in your males than in your females. And so that's known as liability. And so what that means is that males need fewer risk factors to reach that disease phenotype, whereas females need more risk factors to reach that phenotype. And it's often thought that the risk factors are going to be inherited risk factors that when it's mixed with the environment, you can reach that disease phenotype. So an example of threshold model is pyloric stenosis, the narrowing of the pylorus, which empties from your stomach into your intestine. And so there is a prevalence in Europe of every 3 out of 1,000 births. It can be corrected with surgery. And males are going to have a much lower threshold because every 1 out of 200 males are affected. Females are going to have a much higher threshold because every 1 out of 1,000 are affected. And so females are going to have are going to need more disease-causing influences in order to cause the disorder, and males are going to need fewer influences to cause the disorder. And so this has an impact on first-degree relatives. So first-degree relatives, if you have a male with pyloric stenosis, then you have a lower threshold of getting that disease. However, if you have a female with pyloric stenosis, then the prevalence of the disease will be much higher, or the probability of disease will be much higher in male siblings, for example, because the female has more influences that are probably going to be also passed on to male siblings. And since they have a lower threshold to reach the pyloric stenosis, more males with an affected female sibling will also likely be affected. So that brings us to recurrence risks. So recurrence risk means what's the probability of your affected first-degree relatives. And so we have, in this example, this is again pyloric stenosis, we have male probands and female probands. And of course, a proband means they're presenting with disease. And so if you have a male proband, remember males have less risk factors that will lead to the actual disease. You have a recurrence risk in male probands from London of 3.8 and then at Belfast of 9.6. And so this goes back to the population prevalence of these genes. And then sisters, of course, are going to be lower because they require more risk factors in order to get pyloric stenosis. They have a higher threshold, and so they're going to be lower. Now, if you have a female proband, you can see that the numbers go up significantly. So now a female proband, the brothers are 3 times more likely to have pyloric stenosis. And in Belfast, it's almost 1.5 times more likely, but in London, it's almost 3 times. And then you have your female probands are affected. There's equal likelihood of females being affected between London and Belfast, but it is an increase as compared to male probands. Now, other diseases that follow this same sort of threshold model are cleft lip, cleft palate, or clubfoot, neural tube defects, as well as congenital heart disease. All right, so as a comparison, our single gene disorders for autosomal dominant with complete penetrance would be 50%. A multifactorial disease, we can't use that simple percentage that you use for single gene disorders. And so they have to use what's called empirical risks. And this is going to require a lot of data sets, a lot of families to be followed. Just making sure it's recording. Families to be followed, and you need a lot of, as I said, a lot of data. And so neural tube defects was studied because they were pretty prevalent before it was discovered that folic acid could help to reduce them. And so with neural tube defects, it's found that you have about 2 to 3% recurrence risk with these defects. Now for neural tube defects, there's 3 main types of neural tube defects. The most common is spina bifida, and over time, and especially with folic acid, survival has increased. You can do surgery many times to help a baby born with spina bifida. Anencephaly is typically a baby is going to be born dead, or unfortunately die within hours or days after birth. And then we have, of course, your encephalocele, and so that is where you have protrusion of the brain. It's actually in a sac, so it has its own sac, but it's not in the skull. And these also are dead at birth. Now, the empirical risk for siblings, again, first degree, is about 2 to 5%. However, if you have additional affected siblings, you're going to increase your recurrence risk. So about 3% if you have one sibling born with neural tube defects, and that jumps to 12% of 2 and 25% of 3. So it jumps very dramatically the more you have. Now, the diagnosis is an increase of alpha-fetoprotein in maternal serum or amniotic fluid, and you're going to treat or supplement with folic acid, has decreased neural tube defects presentation. And folic acid gives folate, tetrahydrofolate, which we're going to learn in biochemistry is one of those important single carbon donors. And when you're starting to build things, you need to add carbons. Those single carbon donors become critical. And if you have a deficiency of folic acid, or if your baby is not getting enough from the mother, then you're going to have a serious impact on growth. Okay, so how do you tell the difference between multifactorial diseases versus single diseases with incomplete penetrance? And just like I said before, to study multifactorial diseases, you're going to need a lot of large data sets, as well as good family history. And you know, by doing your family history, a lot of times it's hard to get family history, especially when relatives have passed on, and you're just relying on the knowledge of the most recent relatives to explain past history. In addition, until about the last couple of decades, genetic history wasn't really kept in families. And so it's important, though, to start so that future generations will have the information they need. So one thing to keep in mind with multifactorial diseases is that your recurrence risk is higher if more than one family member is affected. So again, this goes back to spina bifida example, pyloric stenosis as an example. The more that you have affected siblings, the more likelihood of a sibling being affected. And in addition, if you have a proband that has a more severe form of the disease, that indicates that they have more risk factors they've inherited. And so the recurrence risk for first-degree family members is higher. In addition, if the proband is the less commonly affected sex, so again, we go back to pyloric stenosis, if the proband is a female, then the reoccurrence risk of the first-degree relatives is going to be higher. If you have remotely related relatives, then you're going second-degree, third-degree relatives have pyloric stenosis, but none of your first-degree relatives do, then the recurrence risk of the disease in your particular first-degree clade grouping is going to be lower. You have a prevalence of disease in a population, and the risk of the offspring of the proband affected is a square root of F. So if F is 50, then the risk of offspring of a proband would be the square root of 50, for example. So multifactorial versus single gene inheritance. Again, multifactorial is going to have multiple influences. Often the distribution is going to be bell-shaped curves in multifactorial. Single gene inheritance is going to follow Mendelian inheritance patterns, autosomal dominant, autosomal recessive, etc., whereas multifactorial does not. You have recurrence risks. Often there's a threshold that you have to reach in order to have or present with the disease. And depending on the proband, depending on the severity of the multifactorial disease, will have influences on whether or not first-degree relatives are going to have the same disease. Now, twin studies have been looked at for identifying what diseases are mostly going to be genetic and which diseases are going to be influenced by the environment or both. So you can think about a disease that's completely genetic would be Down syndrome. You can think about a disease that would be 100% environment would be influenza infection. And then you have these in-betweens, which could be anywhere from heart disease, pyloric stenosis, clubfoot, etc., that are going to have both genetic as well as environment influences. And so we have concordant and discordant. Concordant simply means that you have siblings that have the same phenotype. They share a phenotype. And cleft lip would be an example of a concordance. Discordant means that siblings do not share a trait. So one sibling gets a cleft lip, one does not. The reason to study twins is because monozygotic twins are, in theory, genetically identical except for in their immune system. And so studying monozygotic twins, especially ones that are reared together or ones that are reared apart, you can really look at environment. You can also look at if there is influence more by environment or more by genes. So the higher the concordance of a monozygotic twin, the higher the probability that it's genetic. The lower concordance between monozygotic twins, the more likely it's going to be influenced more by environment. And monozygotic twins, when they reach adulthood, typically go off to different environments, and that's where these multifactorial diseases really take shape. Some monozygotic twins might go into a more stressful environment and have higher blood pressure, and then the other twin might go to a more relaxed environment and not have higher blood pressure. So you can look at the influence of the environment, for example. Now, dizygotic twins are going to be similar to all other siblings. So if you have a disease that's influenced by genes only, you're going to have the same concordance level as just with siblings. So you're going to be less concordant than monozygotic twins. So the correlation coefficient between intra-class, intra is within, is going to range from a -1 to a +1. And so if the trait is by genes only, then you have a +1 for monozygotic twins and 0.5 for dizygotic twins. If the correlation is 0, then you have a similarity of both monozygotic twins is the same as chance. And then, of course, in the -n, it's not influenced by genes at all. So that would be like the influenza, for example. So with sharing of alleles among relatives, if you have a proportion of alleles in common with the proband, is related to your relative degree. So monozygotic twins would have a 1 because they are identical. First degree relative, you share about half. Second degree relatives, 1/4, and third degree, 1/8. And so if you have siblings, the average number of alleles that you share with your siblings is going to be 2 alleles, about 25%, 1 allele, about 50%, 0 alleles, about another 25%. And so that's the distribution of these alleles. And so this leads to concordance, the ability to measure concordance among relatives of different degrees. So if you look at just your monozygotic twins, which are going to be concordant with respect to their genetics, with dizygotic twins, which are similar to just siblings, they don't have the same genes, and you can look at whether or not a disease has more of a genetic or perhaps more of an environmental influence. So you can see with epilepsy, non-traumatic epilepsy, monozygotic twins have a concordance of 70, which is very high. So that means it has a very high genetic influence. And then also type 1 diabetes is relatively high, and that has to do with their HLA alleles. Schizophrenia, bipolar disease are going to be relatively concordant, so they have a strong genetic influence. And then psoriasis also has a very strong genetic influence. Now, again, when you take monozygotic twins, separate them at birth, and children are especially important to study because they don't make choices. They don't choose where they live. They don't choose where they go to school. They don't choose what foods they eat. So they're really influenced by the environment that they're in. So if you take monozygotic twins, separate them at birth, then you can look at environment because they're not going to be raised identical in the same environment. And so one thing that was found with monozygotic twins is that they had concordance for alcoholism. And so that suggests that there is a genetic influence with respect to alcoholism rather than, or unless they were both in alcoholic environments, but there might be a genetic influence in that. Now, some things to keep in mind with twin studies is that you can look at them especially with respect to concordance of genetic influences, environmental factors. However, they are going to be limited. And some of the limitations are that the environment can change. So monozygotic twins that are separated at birth, their environments will be different. Monozygotic twins that grow up and then move to other places are going to have environments that change. You also have somatic rearrangement in the immune system, so your antibodies and T cell responses can be different. If you're females, monozygotic twins, there's also X inactivation, which is random, as we know, and so that could influence diseases in the twins. The development of the fetuses can be different. So they're going to share the same placenta. Oftentimes they have different oxygen supplies. You hear about one twin being larger than the second twin, for example. And so that's very common in twin births. And so the environment that they're exposed to at the very beginning can have an influence on their presentation of diseases, which might not be concordant because of their environment. Okay, so some of the characteristics. We have talked about Mendelian patterns of inheritance. So these guys do not follow that, of course. There's familial aggregation, especially those that have greater influences of genes, and especially if you are reaching that threshold within your family, which means that the traits that are predisposing to a particular disease have been aggregating and are now passed on to the generation you're studying. They are going to show a lack of penetrance, even if you have the disease phenotype. And this is going to be due to other influences, such as I said, for high blood pressure. You and your siblings might share a similar risk factors for the traits that were passed on to you from your parents. However, one sibling may have high blood pressure due to environment, and the other may not develop high blood pressure due to environment. But it's important to understand if you do have those risks so that you can alter your environment to negate the environment side of it so that you don't present with the actual phenotype. And of course, how related you are to the proband. So first degree are going to have more risk than your second, third degrees, for example, relatives.